Most people don't know that knee arthritis can be treated naturally without invasive surgery or drugs. So if you've been told that you need knee replacement, this might change your entire treatment path. We get the question all the time about what the difference between PRP and actual stem cell therapy is. And for the most part, there is a significant difference. Both are biologics, both are acquired from the patient themselves. But PRP are blood components. So this is whole blood that's taken from the individual. It's spun down in a centrifuge so that we can collect platelets, growth factors, and proteins in plasma. And PRP stands for platelet-rich plasma. So essentially that particular substance does provide a healing resource, but it's not necessarily designed for advanced conditions like an arthritic condition. Stem cells are acquired from bone marrow. So what we do is we aspirate the fluid within an individual's bone, and we isolate the actual stem cells or specialized cells that exist within it. And it also comes with significant growth factors. And the real main difference really is that PRP is acellular, and stem cell therapy obviously has living cells or living viable cells within it. Now, where the difference comes in is really in target tissue or condition. For those individuals that have a less significant condition like a tendinitis or a soft tissue issue, then PRP can be very useful at promoting a long-term outcome. If we're talking about stem cells in PRP, think of them like seeds and fertilizer, or construction workers and raw materials. It's probably the best analogies that I have. But imagine like seeds and fertilizer. There are certain tissues that just need to be fertilized. We need to initiate a healing process within that tissue because there are satellite cells that already exist within it. And by adding fertilizer or PRP, we can encourage that tissue to heal to completion, let's say. Now, if there are tissues that don't have either blood flow or specialized cells within them, and think of like connective tissues like cartilage, joint capsules, discs, ligaments, those tissues specifically, when those become injured, either a result of a chronic process like arthritis or a result of an injury, then typically we need both seeds and fertilizer because that's going to produce the best long-term outcome. So there's a lot of common misconceptions about what arthritis is to begin with, not necessarily just knee arthritis, but arthritis in the body. And there are various different types of arthritis. But what we're really speaking about is the chronic, the degenerative type, the wear and tear type of arthritis. It's called osteoarthritis. And it's not something we catch like a cold or a flu. It's something that develops over many, many years. And there is a wide range of severity in terms of arthritic conditions. There's the beginning stage, and then as it progresses, it gets worse and worse. And then a lot of people, they talk about the bone-on-bone arthritis that occurs at the end stage. And that's really just a radiological finding that indicates that the cartilage surfaces and the cartilaginous tissue has worn down to a degree that the bones start to approximate each other. But arthritis is simply just the compounding of damage over a long period of time. We have two types of damage that can occur in our body. We can get hit by a bus and it can cause damage all at once, and that's easy to understand. Or we can have small amounts of wear and tear that, compound over long periods of time that create the same amount of damage just in a different time frame. And people come to us with, knee arthritis or osteoarthritis of the knee, in various stages of that particular condition. So how we go about solving for knee arthritis will really depend on, where they are in the stages of the arthritic condition. And we have a scale that we utilize. It's called the Kellgren-Lawrence scale that grades it 1 through 4. And it's based on radiological evidence, right? So if we take x-rays of somebody's knee and we see that the compartment is thinning and we see that they're starting to lose cartilaginous tissue, then we can grade it based on where they are in terms of severity and then decide what's the most appropriate resource to not just solve for the cartilage damage, but get them back to fully functional, pain-free, enjoying life and doing the things they love and enjoy, I think the biggest mistake that people make when they start to develop chronic joint pain is they focus on the pain. Right. And that's really common because the traditional model, they really just have drugs as a primary resource. And, basic physical therapy and all of those things are extremely important. But at the end of the day, if we focus on the pain, then what that allows for is the progression of conditions over time until eventually it enters the end stage, and now we're a surgical candidate 10 or 15 years down the road. And over that time frame, we've been able to do less and less and not take part in the things that we love and enjoy. So I think when you're evaluating an arthritic joint, a knee specifically, but an arthritic joint in general, obviously understanding where they are in the stages of development of that condition, but then more importantly, what their goals are. And really, if they want to manage pain, then regenerative medicine may not be the very best solution for them in the short term, especially. And what I mean by that is if the pain is so immense that they can't function in their daily life and they have to get back to work, then the fastest solution would be a cortisone injection. But we have to understand that with cortisone, it comes with downside. Not only does it allow the condition to get progressively worse, but more importantly, it accelerates that process. It damages and weakens connective tissue and will accelerate the degenerative process. So when we're making decisions, we have to kind of understand both sides, right? If we're looking for just short-term relief, it comes with attacks. It comes with degradation of the joint over time and ultimately the end stage of the condition. Now, when it comes to working in a regenerative model and how we manage all varying degrees of the arthritic condition, the tools and resources may be a little bit different. So if it's really early stage and there's absolutely no signs on film of tissue damage in the form of an arthritic process, then obviously we're going to send them into a physical therapy environment. Let's assume that there are no signs of underlying meniscus tear. We don't need an MRI. Then, that patient is a candidate for physical therapy because in that circumstance, physical therapy is going to serve them the best. Lowest barrier to entry, least amount of risk, the easiest way to rehab the joint so that we can get them back to a pain-free state. Now, if the individual comes in and they're showing signs of degenerative change on film, then if it's really early, we may just do some things to control the inflammation, but in a natural way. And that would typically include like PRP protocols. Think of PRP as a natural cortisone, but without the downside, right? So it gives us the ability to control the inflammatory environment in the joint, obviously reduce pain as a result, but it also comes with significant healing elements that allow us to initiate healing in those tissues, control the environment to a degree, and allow that condition to improve as opposed to degrade. Beyond that, once we start to see significant damage, what we have to be aware of is that PRP is a useful tool for controlling the inflammatory environment and healing specific tissues to completion. But in the environment where we start to see damage to cartilage that's more significant than, let's say, grade 1 osteoarthritis, we have to be concerned with the end stage of that process. And in order to really overcome that particular condition in a complete way or in a way that serves them the best, then what we would do is we would bring actual stem cells to the equation because stem cells do have the ability to regenerate tissue. Now, once we start to enter, and this is really the most common thing that we see with knee osteoarthritis, is patients don't come to us early, right? They come to us typically when the condition has gotten to a point where it's affecting their daily life, their ability to be productive, their ability to have fun. But more importantly, it's typically because the medications that they're taking, the cortisone injections, even the gel injections, if they progress to that level, are not providing them with the relief that they want. And literally the next available tool is surgical intervention. And maybe they're not candidates for that right away because they're too young. Maybe the condition isn't significant enough that it makes sense to do surgery at that stage of the game. Or maybe they just don't want surgery because they're afraid of the possible outcome. Maybe it doesn't work, or the risks that come with it, or the possible downtime and recovery time that comes with knee replacement. In those cases, we can provide a great amount of resources to help that individual improve long-term using both stem cells and PRP. But in those cases, the more advanced osteoarthritic patients, we do require both tools. So it would be appropriate to harvest stem cells as well as PRP from blood. And then, obviously follow that patient and give them, ancillary care in terms of stacking the deck so that they can improve over time and doing the best we can to get them back to a pain-free, fully functional state and prevent or prolong the need for surgical intervention. We're here to provide value. So at the end of the day, whatever the goal is for that particular individual, we're going to make the necessary recommendation that's in line with our core values. I don't care about knees. I care about long-term health. I recognize that being sedentary is completely detrimental to your long-term health. And more importantly, prevention, again, is the best tool in medicine, right? So with the understanding that I have about the progressive nature of the osteoarthritic condition, when I see somebody who's grade 1 or grade 2 who really just wants to solve for pain, I always have the conversation about, look, we can solve for pain in a natural way. We're never going to use cortisone. It's against kind of what we believe in, and we believe there are better tools. But at the end of the day, if they want just short-term pain relief and they're choosing, let's say, PRP, I always have the conversation that, look, PRP is extremely useful. We may get a year's worth of relief from one injection. It is the most minimally invasive thing that we do. However, there's something that you need to understand, and that's that you're already at grade 2, and progression of this condition, once it enters the end stage, remember, it's really hard to unboil a hard-boiled egg. So we don't want to allow conditions to get to that point because we recognize that down the road, you may be able to do less in terms of your ability to maintain your health through exercise. And that doesn't even account for the fact that, maybe they can't play with their kids or do the things that they love and enjoy. And that becomes an issue too. The indication for regenerative medicine is never in situations where the patient is immediately surgical. Right. So part of our evaluation requires us to determine, is surgery the best option for this particular individual? And there's a wide range of what that means, right? Like, let's talk about meniscus tears if we're talking about knees. Some meniscus tears require surgery, but many of them don't. And the best solution in the majority of meniscus tears, especially chronic ones, is regenerative medicine, in my opinion, because the surgical outcomes are really poor. However, certain meniscus tears absolutely require immediate surgery because that's the best tool for that particular individual. When it comes to osteoarthritis, that's a little bit more of a difficult discussion, right? Because what we have to understand is the hierarchy of replacement surgeries and, what those clinical outcomes look like. What are the risks? What's the downtime? What's most important for that particular individual? And when I say hierarchy, what I mean is, certain replacement surgeries go really well. They're highly successful and there's very little downtime and patients are back mobile in a very short period of time, most notably like hips. But then once we kind of get into knees and even shoulders and spines specifically, then the likelihood for success is not as good as most people realize. So there's a percentage of individuals who have residual pain, even post-surgical, but more importantly, the downtime and the recovery time becomes a little bit more significant, if you will. So we have to really weigh both sides. Now, if somebody comes and they have a lot of metabolic issues, they're severely overweight, and they have severe tri-compartmental, or all three compartments are damaged at grade 4, regenerative medicine is probably not the best tool for that individual. However, we do treat a lot of grade 4 osteoarthritis, and the literature is really clear, actually, in grade 4 osteoarthritis, so long as we're using both stem cells and PRP, that we can provide tremendous benefit for those individuals in the long term. So when it comes to osteoarthritis, I know there's a lot of questions. If you have any questions, please leave them in the comments. I'll do the best that I can to get back to you. And if you know anyone who's dealing with osteoarthritis or chronic joint pain, please share this video with them.